Good afternoon, my name is Dana Daniel, and my major here at UMBC is pediatric health psychology. Before I begin, one moment, sorry. Okay, I'd just like to thank my faculty advisors, Dr. Sean Bediaco, Dr. Robin Majeski, and
raise your hand so we know. Thank you very much.
And Professor Stephen McAlpine for all their hard work and dedication to this project. I'd also like to thank Dr. Lanu and all the INDS faculty members that provided a lot of feedback along the way and really helped me shape the project into what it is today. So with that said, I'll begin with a little bit about myself. When I was 8 years old, I was rushed to the emergency room by ambulance, where I was later diagnosed with a cardiac disorder called supraventricular tachycardia. So just by a quick show of hands, how many of you are familiar with that condition? Okay, a few of you. Well, at the time, I was not. And in fact, I wasn't told much more than what I just told you a moment ago. I remember sitting in the exam room and watching the interaction between the cardiologist and my parents, and sitting there quietly with all these questions rushing through my head, really just trying to keep from crying. From that point on, it was a difficult adjustment for a couple of years. I can only explain an episode of SVT to you as what you might expect a heart attack to feel like. So where a normal heart rate is around 70 beats per minute, mine ranges around 230 beats per minute. In addition to that, I get severe chest pain, shortness of breath, and so the episodes themselves were a very traumatic experience. But even more so than that, it was this constant fear of dying that was even more so taxing. And that lasted for a couple of years. I also kept my condition a secret from most of my friends. I was really afraid of people treating me differently. And so throughout my childhood, it was a pretty difficult adjustment. When I started working in the hospital environment, I became really interested in oncology. And it rose questions in my mind about the experiences that these children go through and how they might compare to that of my own. So that's really what sparked my interest in this project. My main purpose was to find an effective way in which pediatric oncologists could aid in reducing a condition called pediatric medical traumatic stress, or PMTS, in children with cancer. I hypothesized that by providing psychosocial training to these pediatric oncologists, there would be a decrease in the prevalence of the condition among their patients. Before I go any further, I think it's important to note that throughout this presentation, it is not my intention to suggest that pediatric oncologists play a sole role in reducing or preventing PMTS, but rather that it should be that they should contribute in the following ways in what should be a collaborative effort among other healthcare workers, certainly family members, and medical practitioners in some severe cases. For my project, I conducted a literary review of peer review articles. I also conducted a textual analysis of the current training modules provided to medical students. So what is PMTS? The National Child Traumatic Stress Network defines it as a set of psychological and physiological responses of children and their families to pain, injury, serious illness, medical procedures, and invasive or frightening treatment experiences. It's classified as post-traumatic stress symptoms. Although it's a continuum of the PTSD symptoms, it doesn't necessarily fit the criteria for the full disorder. Those symptoms include re-experiencing the event through persistent thought, nightmares, flashback, avoidance of activities that they normally find enjoyable, or avoidance of activities that actually remind them of the trigger, and then hyperarousal, this elevated state of excitability. So what causes PMTS in patients with cancer? This could be anything from death anxiety, misperceptions of the disease, not knowing what it is and what it's doing in the body, medical procedures or instruments. This could be anything from IVs, syringes, chemotherapy, radiation therapy. And then, of course, the overall experience of being in a hospital. That in itself can be very frightening. So let's now visit the current issue with respect to the oncologist. Primarily, the focus of the oncologist is focused towards the parents of the patient and what we call a dyadic interaction between the practitioner and the parents. This is especially true with young and school-aged children. Even in instances where the oncologist is asking questions about the child, where the child is present and capable of answering, they still direct these questions towards the parents. And so often the child is left outside of this conversation involving their own health care. In addition, current physician training acknowledges the need for rudimentary understanding of child development and the use of age-appropriate communication, but little to no formal training is offered to these physicians. So essentially, integration of this nature is left to the oncologist's discretion. So hopefully at this point, it's easy to see that addressing PMTS requires an interdisciplinary approach. In terms of biology, the oncologist must be able to have a profound understanding of the pathogenesis or the mechanisms of the cancer in order to educate the patient and the parents. Embedded in that education are psychological themes. The practitioner must be able to take that medical jargon and the concepts and translate it in a way that will be understood by the patient. Of course, this is dictated by their cognitive ability. The oncologist must also have a general understanding of recent potentially traumatic experiences that that child may have underwent. So in getting a patient history, they should include questions about recent death in the family, or just a recent loss in general. It could be anything as trivial as loss of a pet that could have a pretty significant impact on their current perceptions. The oncologist must also have a general understanding of child development so that they can identify or distinguish the difference between what is typical behavior and what is considered maladaptive behavior in order to either address that maladaptive behavior themselves or make the appropriate referral. From a sociological standpoint, the oncologist must be aware of the dynamics of the interaction itself. So with respect to pediatric medicine in general, it should always be a triadic interaction between the practitioner, the patient, and the parents. Research has shown that this particular type of interaction greatly enhances treatment adherence. So it's important for several reasons. In addition, the oncologist must have an understanding of how the family's adaptation affects the adjustment of the child. So in particular, they should look to the parents and see how they're adjusting to the diagnosis and the treatments. In a study of 150 families of adolescent survivors of childhood cancer, 99% of those families had at least one family member with PMTS, and 20% of them had at least one family member with PTSD. So this should highlight something important. Pediatric cancer does not just affect patients, it affects the whole family system. And because parents are often the most prominent sources of support for their children, it's important that we address their adjustment and that we provide them with the necessary resources to better help their children cope as well. So what psychosocial training exists currently? Through my research, I found one training module created by the Children's Hospital of Philadelphia, along with the National Child Traumatic Stress Network called the PMTS Toolkit. And essentially, it integrates much of what I've been discussing so far, but there were some areas where I felt it could be improved. Specifically, through my research, I found a technique used by psychologists called play therapy. This uses the medium of play to either prevent or resolve psychosocial training or psychosocial issues in young children. I don't have time to go into the rationale, but research has shown that this is highly effective, and it's used in and outside of the context of medicine for that very reason. So play therapy can be used on a small scale in pediatric oncology as well. For instance, when an oncologist is presenting a new treatment or procedure, they can allow the child to engage in role play, such as seen in the picture here. This allows the child to become familiar with potentially frightening instruments, and it also gains them a sense of ownership. Another shortcoming I found was a lack of emphasis on metaphoric language and sensory tools. So research has shown that at the young age of 4, a child can appreciate the simple use of a simile when it's paired with visual and tactile or touch stimuli. So incorporating all these modalities of learning in one approach can greatly enhance a young child's understanding of something so abstract as cancer. The integration strategies I used were building multi-causal and complex explanations. Here I looked at the phenomenon of PMTS through the lenses of psychology and sociology, where no one discipline could address it fully on its own. I also used bridging and explanation and action gap. This used multiple disciplines to approach current shortcomings in the traditional model. Here I'm promoting a biopsychosocial approach as opposed to the traditional biological approach. So in conclusion, if 14 years ago my cardiologist used some of these themes that I've been discussing today, it would have made the world of a difference for me. And I can only assume that it would make the world of a difference for these children as well. Aside from my own personal experience, while there is much more research to be done in this area, the current research suggests that providing psychosocial training for these pediatric oncologists could greatly benefit the collaborative effort to reduce PMTS in cancer patients. So, thank you. Is there any more questions?
Have you found some practitioners who are ready to practice, put this into practice for you?
The hospital I mentioned, the Children's Hospital of Philadelphia, has administered this training program to both their physicians and their nurses. Unfortunately, there wasn't any studies done on how it affected the prevalence of PMTS, but they did take a survey in 2004, I think, of 173 physicians and nurses, and asked them, they broke down the toolkit and asked them, based on each component, how they thought it helped them deal with pediatric patients. And from what I saw, most of them thought it was very helpful. So, other than that, I don't have any other stats, but it is available for the public.
So would you consider writing a pamphlet and putting it in the waiting area or the doctor's office for parents who could understand this by virtue of reading about it and at least maybe take some steps?
I think that that would be a good idea. The Children's Hospital of Philadelphia, they're really the pioneers in this field. They've also created intervention for families, for parents. So I think that that has been proven extremely effective. And that's where their main focus is now, just targeting the family. Whereas my interest was on how the oncologists could contribute to that effort.
Sure. Questions? Well, thank you very much, Dana. Really appreciate it.